suppose that the IT, or now increasingly informatics, has always reflected the fashions and consensus about medical practice that take place not only within the health service but also elsewhere. There was one particular example in our search for a kind of holy grail of indications and risk factors in the specialty, where a paper was published in the early 90s showing a relationship between serum albumin and relative risk, and it was a linear relationship in renal patients. And thereafter we chased that, often perhaps unconsciously, examining very carefully the various laboratory attributes of patients. And we did that certainly for the decade after 1995, and we didn't really come up with anything else that was anywhere near as good. But I think in retrospect it suggests to me that one can have unconscious drives that can potentially be very wasteful. And I think it occurred because the data from laboratories was so plentiful and available. And of course we always seem to follow the easiest thing to do, which is not wrong, but the problem is obviously that can be, that's a little bit like the drunk looking for his keys under the street light, you know. That hasn't proven to be so very useful. And although we did what other registries have done, which was to document the improvement, for example, in dialysis dose, the improvement in renal anemia and that kind of thing at unit level, there were no other necessary revelations in that, and many of the conundra about laboratory variables remain. It's also the informatics has in particular served the huge development in audit and evidence-based medicine, of course, although that in recent times has descended into a certain amount of argument. But then some new things would not be possible without it. So particularly in the States, but increasingly here, the idea of tying investment, health investment to outcomes and the values of diagnosis and treatment simply aren't feasible without digitisation, and it remains to be seen what balance will be found in that in future. Yes, in clinical computing, in the US, as I understand it in particular, the funding authorities, whether they be the insurance companies or Medicare or equivalent, have had a very big influence on the digitisation of clinical consultation, and so the modern currents of risk aversion, interests in safety, interests in protocol, interests in clinical pathways have inserted themselves thoroughly into the way that practice is seen to be recorded. So this is in complete contrast to the early efforts that we explored with the clinical computing, where the database was there for interrogation by the clinician within consultation, but it was all instituted from the clinical side and from the point of view of the need of the consultation at that moment. There were no external drivers. The screens could not be blocked. Items did not have to be entered, and so on. And clearly, there's a balance to be struck in that, as there is in the use of the computing in consultation generally. Is it an exemplar? Is the screen to be shared with and shown to the patient, or is it actually a secret mechanism for the clinician? And of course, there's a huge variety of styles in that. But as far as nephrology went, certainly early on, it was a boon within consultation. We might now ask whether it has any place there at all. And I gather in the US that clinicians are having to use lay staff to make their entries because the appetite for data has become so gargantuan.